RetinaRounds, episode number 97, T-sign in posterior scleritis. Today's episode will serve as a supplement to our B-scan basics videos, and for more on an overview of B-scan ultrasonography and diagnostic tips, please be sure to check out episodes number 73 and 74. Here we're going to show you a very helpful diagnostic test in patients with suspected posterior scleritis, and at the end we'll have a brief overview of posterior scleritis signs, workup, and management. We want to thank our returning contributor, Dr. Abbas Haider, for sharing this video. Okay, so let's take a look at this B-scan, and first you'll see that it is an axial scan since the shadow of the optic nerve is in the middle of the ocular image. The ultrasound probe is being moved in a limited fashion laterally to bring the optic nerve into view, and the most pathognomonic finding of posterior scleritis here is the so-called T-sign. So you can see a hypoechoic layer that's just posterior to the sclera. And when we look at this hypoechoic layer adjacent to the optic nerve, we can see that this layer in combination with the shadow of the optic nerve forms a T shape. So why does this hypoechoic layer form? Well, in cases of posterior scleritis, the inflammation can result in fluid accumulation overlying the sclera. And in fact, that inflammation can result in fluid accumulation not only over the surface of the sclera, but also in the adjacent choroid. And you can see that in this ultrasound, the choroid appears to be much thicker than normal. And while choroidal thickening can be seen in a variety of conditions, this combination of a T-sign and choroidal thickening is highly suggestive of posterior scleritis. Now you can also see here that the vitreous cavity looks to be quiet with perhaps only a little bit of vitreous syneresis, and that really helps the physician to rule out other disease entities such as panuveitis, as might be seen in VKH disease or endophthalmitis. So here are your take-home points. Posterior scleritis can have a number of associated signs and symptoms, but perhaps the most typical clinical feature is its association with deep, sort of a boring ocular or orbital pain, and this pain may even wake patients up at night. Now, since posterior scleritis by definition is in the posterior wall of the eye, the anterior surface of the eye may appear relatively quiet with very little redness or pain to palpation anteriorly. Other signs may include proptosis, ocular motility disturbances, and orbital inflammation. Now, in fundoscopic exam, one might see choroidal thickening with chorioretinal folds, serous retinal detachments, and even nerve edema if the scleral inflammation is compressing the optic nerve. Now, since posterior scleritis can be associated with other systemic inflammatory conditions, one may also see signs of retinal vasculitis, which can include retinal vascular sheathing, exudates, and hemorrhage. Imaging can be very helpful to arrive at a diagnosis of posterior scleritis, and ultrasonography, as is shown in this case, is one of the best diagnostic tools. Enhanced depth imaging OCT can also show choroidal thickening and serous retinal detachments. And while fluorescein angiography may be relatively nonspecific for posterior scleritis, one might see pinpoint hyperfluorescence or signs of retinal vasculitis. So in these cases, systemic workup is absolutely critical since these patients often have associated systemic conditions that can be either vision or life-threatening. And infectious etiologies such as tuberculosis and syphilis should definitely be ruled out, and this is especially true since immunosuppressive anti-inflammatory therapy that's typically used to manage posterior scleritis can make infectious processes worse. A number of rheumatologic conditions can be associated with posterior scleritis, but rheumatoid arthritis is by far the most common. Other systemic rheumatologic conditions include lupus, sarcoidosis, granulomatosis with polyangiitis, polyarteritis nodosa, and others. One of the key take-home points here is that consultation with the rheumatologist is highly recommended, not only to help identify the underlying condition, but also they'll be helpful to aid in management. Now, posterior scleritis can be treated with oral NSAIDs, although often in these patients, systemic steroids may be necessary, and that can include either oral steroids or even high-dose intravenous steroids in more severe cases. And while there are reports of periocular steroids being beneficial in patients with scleritis, these should generally be avoided in cases of necrotizing scleritis, and that can be really difficult or not possible to ascertain in cases of posterior scleritis. And lastly, steroid-sparing immunomodulatory therapy may be necessary in cases of either chronic or recurrent posterior scleritis. This is a great demonstration of the ultrasonographic features of posterior scleritis, and we want to thank Dr. Haider again for his very helpful contribution. Thanks for watching. If you enjoyed this video, please visit us at RetinaRounds.com. There you can sign up for our email list. You'll get a notification every time a new video is posted. And if you have an interesting video or a tip or trick that you'd like to share, please follow the links on our website and you can upload your video there. Thanks so much for watching.